So I hope everybody slept well. We're going to see if everybody is a neurologist now after yesterday's day. Or a radiologist, sorry Vera. It's my thinking. Yes, so this morning I have brought you some clinical cases. Let me see if I can get this here. Recording in progress. And a very small recap of what we discussed yesterday. So if a patient presents to our clinic, there are 4 questions that we needed to consider. First, are the clinical symptoms that we see, are they typical of demyelination? Then do we actually see demyelination on imaging scans or imaging, so MR scans or OCTs? And then the big question is if there is dissemination in space and time, meaning that there is a high risk of a next demyelinating event that can either be MRI lesions or relapses, because lesions always lead to relapses. And then last but not least, the most difficult one is there no better explanation for the clinical presentation. Who remembers the 5 localizations from yesterday? Juxtacortical, yeah. Only 4 to go.
Spinal cord.
Spinal cord, yeah. Optic neural, infratentorial.
And the most common?
No?
We have that?
Periventricular, yes, that's correct. And do you know the most common symptoms leading from those lesions? Or complaints, you could also say? Eye complaints, yeah. Double vision, yeah. Yeah. So the complete mobility things, loss of strength.
Bowel bladder.
Bowel bladder, also an important one, yeah. And the most common one? Sensory problems. So tingling sensations, numbness, or also sometimes a loss of coordination. Yeah, and then you basically see this, remember? So the typical clinical picture in an untreated patient where you see multiple relapses over time in different systems, either recovering or not fully recovering. So here are the localizations, very good. On the scan, so we have the juxtacortical lesions, the most common ones, the periventricular lesions with the Dawson's fingers if you were to look at a sagittal slice. Then you have the optic nerve here, the infratentorial lesions in the brainstem and the cerebellum, and here you have the spinal cord lesions. And dissemination in space is that you need 2 out of 5 locations. Then the second one, the new one, I would say, the imaging of the optic nerve, the retinal nerve fiber layer here, and as you perhaps can remember from yesterday, that thinning of the retinal nerve fiber layer, so when it's in the red areas, is quite indicative of damage to the optic nerve. And you can see either that after an optic neuritis, but also in patients who had inflammation of the optic nerve asymptomatically, so without any optic neuritis. Yeah?
Eva, I have a question. Are we expecting the optic nerve thickness to be the same throughout the optic nerve, or is it supposed to make all these, wiggly behavior?
Yeah. Yeah, so the wiggly behavior, part of it is normal because of the vessels. You can see them here. And also there is differences in the thickness, basically based on the area. I think it was temporal, but perhaps you know that better, that you can see temporal thinning.
Yeah, you would expect more temporal thinning, but this is, in the OCT you can see this is just inside the eye, so this is like a retinal nerve fiber layer. This is different than what you see in the MRI. MRI is the axons of the optic nerve, so you may see some focal atrophy or some hyperintensities due to the optic nerve insult, but in this OCT you would expect some thinning, but it's mostly the temporal layer thinning in MS optic neuritis. You can also see in the OCT that there is a thinning in the ganglion cell layer, which is the ganglion cells that consist some neurons.
You have multiple layers here.
Neurons, and these axons actually forming the optic nerve. So it's also possible to measure that layer as well.
Yeah, you can also have thinning in eye diseases. So you can see it in glaucoma, for example, or refraction disorders. So that is why we think the optic nerve imaging is we're a little bit anxious how things will evolve in the coming months, because you could get patients referred with the question optic neuritis with an abnormal OCT scan who have actually a primary ophthalmological problem. But we'll have to see how that goes after the implementation of the new criteria. But it is a way of imaging optic nerve damage in the past. So this is, I think, the most important, but also quite a bit complicated scheme of the new diagnostic criteria. And mind you, we're not exactly sure already that this is what it's going to be. But it starts with the questions: does the medical history and clinical examination fit a diagnosis of MS? And then, do you also see abnormalities on imaging and laboratory tests? And doesn't it look like any other disease we saw yesterday afternoon that fits a differential diagnosis? So vascular problems, infections, the cousins and the sisters. What was it again?
Yeah, the cousins.
The cousins, the NMOSD, the MOGAD, and the ADEM. And then if you think, okay, that may fit, that may be MS, you could go for the most easy side, so lesions present in 2 locations, and then you can have a patient with clinical progression and spinal cord lesions. That is a combination of the both, and this is to capture primary progressive MS. And then if you also have dissemination in time, or positive biomarkers in the CSF, or a central vein sign, or lesions present in all areas, then you have a proven diagnosis of MS. This is a more difficult and challenging one. I'm still not able to explain fully, but this also makes it possible to diagnose MS if you have lesions in only one area. So that is new. So you can have a diagnosis of MS if you only have periventricular lesions. And that is different to what we've been telling you guys. So you need two locations, but it's also possible if you have a lot of periventricular lesions with, for example, central vein signs, then you could have the rare case of also diagnosing MS. So if we go to the patient, I thought I start easy with the patient that we had yesterday. So I hope you can remember the scan already. This was a woman, 25 years old, and she presented with walking problems. And these walking problems were due to a sensory problem in the feet that ascended up to the stomach over a period of 2 weeks. She was healthy. And I see I got a neurological examination wrong here. But there was only pathological reflexes on the left. And this was the scan. And can you remember where the problems were? Just shout if you see. Yeah. So this was the problem here. What do you think if you see this lesion? Do you find it a typical lesion, or do you find that it's still dubious if this is demyelination? Dubious? Yeah, for sure. Yeah. Do you know why? Yeah, it's only one. Yeah, you would hope to see more. And the thing is that you can ask yourself, if you only have this slice, if it's in the location that you want to see it. Perhaps you can.
Yeah, we still don't know if it touches the ventricle, so if it's a periventricular lesion or not. It could still be a deep white matter lesion, and that means it has a high chance to be a specific or a vascular lesion.
Yeah.
Even if it's a young patient, if it's a migraine patient, you sometimes see it in young people also.
Yeah. And how do you know it's a deep white matter lesion? That is because of the fact that you see white matter surrounding the lesion and it doesn't touch us.
In every direction.
Yeah. So the every direction is actually a good remark, because you're not yet sure if the ventricle isn't right below it. But now if we go a slice down, then I think you can see that it's white matter. I would say it's white matter.
Deep white matter.
Yeah. But then this one, yeah. So, Vera, if this was the only other lesion in a patient with a proven optic neuritis, what would you say?
Yeah, so first of all, I'm still not quite sure if this is a true pair of, yeah, it's probably touching the ventricle, but sometimes they are just very close. So we just have a paraventricular lesion. We have currently, with the old guidelines, not a dissemination space. With the new guidelines, if we now see optic neuritis also in the MRI scan, we have dissemination in space.
Yeah. But luckily for us, it was a little bit more easy. We had also the lesion here that I think you could easily overlook. And
Which
then
is in the same location type, actually.
Yeah, that's true. It's the same location type, but this one isn't.
Yeah.
So this is the infratentorial lesion. And we also had the contrast scan, the post-contrast scan showed here, if I go down a little bit, enhancement here. And the bigger one here, infratentorial. So that is dissemination in space. And then, of course, and time, yeah.
How about if all the lesions you see in the brain all enhance and you have no non-enhancing lesions?
Yeah, that's a good question. If you see all lesions enhancing, we had an example yesterday. Do you remember what the differential diagnosis is there, the differential? It was also in the demyelination spectrum. Adam, yeah, that's a monophasic disease. Cousin Adam, yeah. So then you can have multiple lesions, very severely affected patient, but if you see them all enhancing, that is not a mess because it's all in the same phase of inflammation. Yeah. Okay, so question 1, does it fit the differential diagnosis of possible demyelination? Yes. Do we need more tests in this patient? Yeah, what tests? I think we're actually there. I think we have an MRI, we have a contrast enhancing lesions. There is no need for an OCT, I think. And yeah, you could do a CSF, lumbar puncture. Some centers do it always. We only do it if it's necessary and if there is no realistic other differential diagnosis that you need to rule out. So I wouldn't do it here. I think this is a typical patient, yeah.
And if I just as a reminder, like say this patient didn't have any clinics and you just by chance find this on an MRI scan, for example, it's a study patient, and incidentally you find these lesions, but there's no clinics. Until now that was RIS, radiologically isolated syndrome. But according to new criteria, I can call it MS already, right?
It depends on the number of lesions and the number of localizations affected. Yeah, so I'm not sure. I think this was the one that was still under the highest debate.
Yeah.
I can remember 4 out of 5 local locations in the brain. So if you have an RIS and you have 4 different locations with extensive lesions, then you could call it MS. But I'm not completely sure, and I have a graph of what it means. Yeah. Yes, so we have 2 topographies, dissemination in time, and now the big question, would you want to treat this patient? Do you want treatment yourself if you had these complaints and know you have MS? Who says yes? Yes, treat me. Yes, yeah. Who says no? Who says I need more information? I need more information, yes. Okay, then you come to me and say, here, this is the folder, this is the information. Please go home, think about it for 2 weeks, and I'll see you back after you made a decision. Yeah, that's still difficult, right? And we've discussed yesterday the different options, the different modes of action, how often you should take it and how you take it, and then of course also a little bit of costs. I decided to leave the costs out for now because I also think that everybody should have access to the best medication that is possible. But hopefully you can remember the injections, the pills, the infusions. And luckily for the thinking, you could also remember that the pills have on average the lowest efficacy. Then you move to, or the injections, then you move to the pills where you have more efficacy. And if you go to the infusions, then you have the highest efficacy therapy. But with that also comes the downside of side effects, which also increases in risk, basically. And as you hopefully can remember, yesterday we had a discussion on the CD20 therapies, the expensive ocrelizumab one and the cheap rituximab one. These are the highest efficacy therapy. We're still often quite afraid of infection, but in clinical practice we don't see it that often. So this is by far the most prescribed, at least in our center at the moment. So if you start the counseling, you start with the first question: what are we actually able to prescribe? And that is a little bit of cost, but also regulations. So the situation in Holland was that we have to choose from certain first-line options, and if these don't work, then you can move to the second-line options. So for counseling, this is already easy. We skip the second-line part, and we're done with the rest. I never counsel people on injections anymore. The one period that it's nice to have them is if there's a pregnancy wish, because you can use it throughout pregnancy. But well, I've never prescribed it. Do you ever prescribe injections? Yeah. Yeah. In what kind of cases?
We just consult with patients that if they choose to take pill every day or take an injection every 2 weeks or. So, and also there's also a possibility of pregnancy. We can use the interferons or axon. Yeah. Another thing that we may sometimes use interferon with MS uveitis. We think that it might help uveitis as well.
Oh, in the eye problems that you can have related to MS.
Problems, most of the time we start with the dimethyl fumarate.
Yeah. So the dimethyl fumarate is the first. Is one of the. Yeah, I think that is the same in our center. So the injections we do not often prescribe. The lowest efficacy pill, the teriflunomide on the lowest end, we also don't prescribe. Then there is this interesting phenomenon where you cannot stop these medications, because if you stop these ones, you have a high risk of rebound inflammation. Very interesting from a biological point of view, because you see much more inflammation going on, and sometimes even tumor-affective types of MS if you stop these medications. So for both older people, where you have a high risk of comorbidities later on, and also for younger people who have a pregnancy wish, well, it's not the ideal solution, because then you're stuck with medications that you cannot easily stop anymore. So skip that part. And then I think you have two options, of which the dimethyl fumarate is the most often prescribed, either in your center and in our center. So we went for the dimethyl fumarate, and the patient stabilizes, and she didn't have any new lesions for, I think, a follow-up for at least 6 years. So that worked quite well. Yeah. Then the next one. So this woman was 56 years old, and she was referred for an abnormal MRI scan. So she had 3 epileptic seizures in the year before. And otherwise in between she felt normal, didn't have any complaints, no neurological complaints, no other complaints. But these seizures happened for 2 minutes, and then you do a workup, and in the workup you do an MRI. And the MRI showed abnormalities. So here it is. We have a flare, we have a PD of the brain and the cervical spinal cord, and we also have a T1 post-contrast. Who sees any abnormalities? Yeah. Could you point to one?
Spinal cord in the cervical and periventricular in the leg, right?
Yeah. So you have this one here. Yeah. And could you comment on how it looks?
It's look lighter than the other rest of the spinal cord.
Yeah. So it's hyper intense. Yeah. And then if you look at the location in the spinal cord, you can have it in the center or in the front or in the back.
I forgot. So it's a back.
Yeah. What do you think, Vera?
Yeah, I see the tongue there, so assuming that this is the front.
So this is the tongue, here. And then you have the back of the head here,
So you've got your vocal cords, where you speak with, your epiglottis, your tongue, your chin. And so this must be the neck where you can grab it.
Yeah, and you see a hyper-intense lesion here. It's only one segment, so it's short, and that is typical of MS. If you see a long lesion, then you must think of the cousins, and the cousins. So cousin A, DEM, cousin NMOSD, MOGAD. I think this is the most important one. And you see here, this is actually a very nice lesion, goes up. You have, this is a periventricular one. I think here, it's difficult to say definitely here, but this is a juxtacortical lesion. And you see also here this tiny bit of contrast enhancement. So, and don't forget infratentorial. Yeah, so we have a spinal cord lesion, we have periventricular lesions, number 2, we have infratentorial lesions, number 3, and of course the periventricular lesions, that is number 4, and we also have contrast enhancement, which is dissemination in time. So, what do we think now? What would be the diagnosis here? Do you think this can be MS?
Yeah.
Can be, yeah. I think the lesions are quite typical. They look typical. They're quite extensive also. So you have dissemination in space and dissemination in time. The only problem is that there wasn't really a fitting clinical syndrome to start with, but that is perhaps solved now with the new diagnostic criteria, and I think this is an example that we would call not a radiologically isolated syndrome anymore, but multiple sclerosis. And one of the important things is that you also see that there is dissemination in time, so you know that there is still enhancement and disease activity. Yes, I think you doubt the medical history and clinical examination, but we do have dissemination in space and dissemination in time. And this is what the inclusion of RIS in the MS flowchart is all about. So this is one of the studies that looked at the probability here of developing MS over time in an average patient with an RIS. And then you could see that here, at least in this data, after 2 years, there was a 20% chance in people with an RIS to develop clinical symptoms, so full-blown MS. And then they did this risk stratification. So they looked at age, they looked at the presence of spinal cord lesions, and they also looked at the presence of gadolinium-enhancing lesions. And then you can see that if you are young, here, 30 to 40, you have the highest risk of developing MS. Also, if you have spinal cord lesions, so this increases quite a lot compared to a person who doesn't have spinal cord lesions. And also here, if you have gadolinium-enhancing lesions compared to no gadolinium-enhancing lesions, that also almost doubles the risk over 2 years. And if you combine that in a risk stratification, you can see that this is a graph that looks at the numbers of risk factors that are present. You can see that the chances rise up to almost 100% if you have 3 risk factors. So that is where you could say if you have a young person with spinal cord lesions and also contrast enhancement, there is almost 100% risk that a patient will develop clinical symptoms anyway. So there you make a diagnosis MS and you could start treatment to prevent that. Yes, now we know everything about treatment. So what shall we choose in this case? It's also a young person. Let's say the patient doesn't have any preferences in terms of pills or injections or whatsoever. I think...
This one was 56 or?
Oh, sorry, this one was 56. Yeah, sorry. Yeah, I'm confused. Yeah.
So probably no babies anymore.
No babies, no, exactly. So that leaves you with the option of the medications that you can continue, or at least that shouldn't be stopped before pregnancy. But still, again, I think if we look at the first line options and the second line options, we will skip the second line options here. We also skip the injections, but that is basically that is what we do. And sometimes you stick to what you do anyway without any arguments anymore. And we would also venture into the pills here, I think. But I have to say, this is what I would counsel patients on, and there is always a room for discussion. So yes, you're completely right. Sometimes people prefer an injection every 2 weeks over pills, two times a day, and then of course you look for the best fitting therapy, in my opinion.
So I have a question.
Yeah?
Yeah, for the highest efficacy treatments, so you said that they will have better treatment outcomes in the later on. So here's we have a young patient. Doesn't matter to any disease, like let's say other than MS.
Yeah, yeah.
So why don't you choose a highest efficacy?
I know, that is the most nagging question that is around, why don't we choose second line option? The honest answer is because we are not allowed to. So the regulations are that you need to start with the first line option, and if you then have breakthrough disease, then you are able to start with the second line option. That is the only way it's reimbursed. But there is one way of getting out, and that is if you say a person has aggressive MS. Well, then you can debate what aggressive MS is, right? And I think if you were to look at the cases that we've diagnosed with aggressive MS 5 years ago and compare them to what we've diagnosed as aggressive MS now, we call a lot more aggressive MS, basically because we also want to prescribe the high efficacy therapy. And that is the true honest answer. Yeah. And I agree, I think in young people that are otherwise healthy, don't have any problems, there is now ample evidence that you should start with high efficacy therapy soon. Yeah.
But after the elimination, you still have the lymphopenia, which is the second line option. Next slide, you eliminated all the other possible treatments, but you still have the lymphopenia, which is second line option. There should be only one possible treatment.
No, the lymphopenia is one of the most important side effects of this one. So the cladribine. So cladribine is a medication where the most prominent side effect is lymphopenia. It's tolerated quite well, so there are no other symptoms.
Sorry, I said wrong then. The treatment cladribine, how you spell it?
Yeah.
Can you go to the next slide? Yeah. You still have the second line option. Normally you said you have yes, you're right. Yeah, so we still have that second line option. That is also because we are now trying to move cladribine to our first line. So we're also allowed to prescribe cladribine in aggressive MS or highly active MS. So that is also sometimes a choice where we say, okay, but this patient has active MS, we really should start with cladribine. To convince also insurance companies that it's okay that we have this type of treatment. Yeah, and I think that in the near future, now that the evidence is so present that the prognosis is basically better after starting high efficacy therapy, this will probably change. Especially if we have rituximab, which also is a lot cheaper than all the other options, I think we will go from that. Who decides for the first line and second line? Like who determines the border for the treatment?
In Holland, I can't explain it. So the reason I can't explain it is that I haven't even put in here that fingolimod, a sphingosine 1 modulator, is a second line option, but the rest, which are almost identical in terms of safety and efficacy, are first line options. So it's a thing that has grown over the years based on regulations, based on historic decisions. And that is what it actually is. So it's not based on any scientific evidence nor common sense. So that's it. And I think now that we've moved these ones to the first line, we never prescribe fingolimod anymore because there's no reason, because you start with the other compounds in the first line. But the differences in efficacy are
well, a little bit there, not in costs. So yeah, this is what it is. If you have any good argument of why we have that, I'm happy to incorporate that in my next talk. Yeah. So this patient was started on dimethyl fumarate, and over time, and that is actually what you said about the lymphopenia, we monitor that. So I thought that is also good to know for you, that it's not only a prescription and then you're done and we see you next year, but people have to come in every 3 months. And if it stays stable, every 6 months to monitor the white blood cell count, because if you go below a certain threshold, and here it's below 0.8, you have a too high risk of infections, and you have to pause the medication for quite some time. So that is also what people not often realize, that there is that if you prescribe these medications, that could have quite some impact in terms of quality of life, because you have to take your medication twice a day, but you also have to come into the hospital for blood checks. And in Holland, even though it's a quite small country, you're not able to do your blood work in the area that you live in if we prescribe it as an academic center, so people have to come to Amsterdam to do their blood work. And that is, yeah, sometimes difficult because you have to drive for 2 hours. Yeah.
Quite weird. I hope in different countries that's different. It's
Yeah.
So they have to come to your center all
Yeah,
the time?
yeah. So we have a central lab, of course, in the hospital, but for all the other healthcare, we have local labs. So if people visit the GP, they can have their blood work done locally. But there is no communication between the labs. So if you do your blood work locally, we never see it. We never get it. So that's why we say that, yeah, you have to come in, because otherwise I can't take the responsibility of monitoring it. Yeah.
I think we have Enabus. Enabus says, right, Sarkhan?
Yeah, you can see the blood work and MRIs and everywhere in Turkey that they can do in
They are
their
connected
hometown,
to
and
the
they can
one
see that.
central
Yeah,
system.
yeah, that's very good. Yeah. Yeah. No, I think we don't have that, and that was decided for based on privacy regulations. Actually, the general population decided against it, because people said we don't want to share, we don't want any information to be shared. But it's difficult in practice. Yeah. Okay, so then this patient, number 3, this is a woman. She's 32 years old, and she was referred for blurred vision. And that started weeks prior to the referral, and for her that meant that she didn't see the colors so nicely anymore, that she also had a problem in the central area where it was even more blurred, so right in the middle of the visual field. And with that she also experienced some difficulties walking. So this one didn't play tennis, but well, I'm not sure what it was, but it was not possible to do that anymore. And that is what we hear quite often. So people go to sports, and then that is the thing that they notice, oh, I can't do it anymore. Football is a little bit imbalanced. So this person also was healthy, and upon examination there was a slight paresis with abnormal reflexes and also a visible coordination problem, and she had difficulty sitting up. So during investigation she had normal blood work, she had oligoclonal bands in the CSF, and this is the MRI that we done. So I start with you guys, and then we move over to Vera, where the abnormalities are. So this is the top, and then we go down again, and who sees things that shouldn't be there?
I think 3 of them were. Can you go back?
This back?
No.
Other back? Yeah?
Top of the head. Yeah, this one. This one.
Yeah?
No?
No, I think this looks normal. This is a normal vascular space. This is, but if you go down, I thought that was what you meant. This and this, yeah. And you could imagine a central vein sign if you see this, this clinical picture here. It's not, you see, it's more difficult, more easy. You see some stripes if you look at the screen. So you could visualize a central vein sign here within the lesion in your head. So we have this one and we have this one.
Do you want me to make it darker for a second?
Yeah, we could perhaps, if that's not too dark. Yeah, people don't fall asleep.
There's never
yeah.
too dark.
There is a too dark. Yeah. Do you see the stripes a little bit better here? Yeah, so this is one here. Yeah, and that this could be the veins, yeah. And this one? Yeah. Here? Yeah. The most prominent one, I think here as well. This is also not normal if you compare this area to this area.
And there were some
Yeah, you spotted that well. So we have here, these are all periventricular lesions. Now if we go down even more, never forget, which lobe?
Temporal lobe.
Temporal lobe, yes, easy to overlook here and here.
Bear in mind that's not one of the 5 locations, but if you see stuff there, it's highly indicative.
Yeah.
It's like,
Yeah, and you're easily thinking, oh, now we look at the infratentorial area, and then you overlook the temporal lobe, and there you also sometimes, in my opinion, you can also find the juxtacortical lesions.
Very often, yeah.
So if you look for,
interior.
yeah.
Here. This is the central vein sign. You see this line going through? Yeah. It's like now it looks like a coffee bean.
Yeah. Yes, so, and I think this is a prominent one, and here we have one, here we have one, here we have one.
There's a juxtacortical, intracortical, infratentorial on the right side. It's in the cortex.
This one?
This one.
Yeah, you're right. Yeah, because you see the foliae of the cerebellum here, the other stripes. Yeah. So if this was the only lesion, could this count as an infratentorial juxtacortical lesion? That was the expert question, right? No, it can. You must fit it to one certain location. Yeah. Yes. So.
Can I ask?
Yeah, sure. Yeah.
You said she has a blurred vision in past weeks. So in here, but when you show the lesions, there are many lesions in her brain MRI. So, like, what is the like when a MS patient understands that there is something wrong in her movements or vision or any other symptoms?
Mm-hmm.
So is it like when you show the explanation for that patient, it says that weeks for blurred vision, but it is like all these lesions happen in weeks, or is it like a broader?
Yeah, so is this all in the same time frame you meant? Yeah, no, often not. So often you see lesions that are older, and you know they are older because they don't enhance with contrast anymore. So then you know that's proof that they are older than the symptoms, if that is only there for 1 or 2 weeks. Yeah, so it's not, in that sense, not monophasic, and the contrast scan really helps in this case. There are some signs here that there is acute inflammation going on as well, because if you look at this lesion, this is quite big. It is also, yeah, you could say it's a bit swollen, and you see edema around it. Yeah, so
not good.
This is the border here, right? The border of the lesion, and this is more vague. So this is, well, I think edema.
For such a lesion, it might also be interesting to see the rim sign, paramagnetic rim sign.
Yeah, I agree. Yeah, this is 2008 though.
Yeah,
so
there was no SWI.
No SWI, no nothing, no. But what we had was gadolinium. So here, this is the juxtacortical infratentorial lesion with ring enhancement. And you were talking yesterday about open ring enhancement. I think you can also see that in infratentorial lesions. And it's a little bit difficult to say, but what that means is that you have some differences in intensity. And you could say that this is perhaps an open area. Here you also have an enhancing lesion, I think.
Do you have any follow-ups with that patient, or do you know about the current situation of that patient, like the medication works?
Yes, we will go to in the next slide. Yes. You will have to start her on treatment first. So the decision is up to you, and then we will see what happens. And here, this is the big one, the big inflamed one with the contrast enhancement. Yeah, so this was quite some activity. And the question is there, should she start treatment? And I hope that you all know by now that the answer is yes. We have multiple lesions in the CNS. We also have dissemination in time and a clinical picture suggestive of MS. And perhaps it's no surprise, but what do you think where we would go to in this case? Natalizumab, no, unfortunately not. No, we started with a first-line therapy. We skipped the injections, we went to the pills, and then we started with the dimethyl fumarate. And that was the choice that was made. But 6 months later, she didn't do so well anymore. So she could not walk anymore. She had loss of hearing, and in a strange sort of way, she was also admitted to an hospital, another hospital, and the medical information wasn't shared. So she was treated there with steroids, and now she came in with us. And what would your idea be on what we should do now?
We'll be going to second line.
Yeah, but first make an MRI. Yeah, so these are the new images. Here, the contrast on the right, and the T2 on the left.
You should have given her Tizapin.
Yes, yeah, we should have done that. Yeah.
Sure.
Yeah. So this is extensive inflammation. One thing that is noticeable is that a lot of lesions show enhancement, and it's quite a lot. So if this were to be the first presentation, I think you should also think for an ADEM. But yeah, in this case, we know that the picture looked different. This is also quite a nice example. Here you see a contrast-enhancing juxtacortical lesion. And that is a thing that you also don't see that often, more in aggressive cases. But this is a severely inflamed brain. And
You see that punctate lesions and round lesions are next to each other. So you can see the variability of the lesions, no? And understand why people might mistake this also for metastasis.
Yeah. And you mean here you have the enhancement of the border of the lesion? Here you have a ring, but here you have a thing that was more punctate. I think it also signed over time.
Yep.
Perhaps they also start with one homogeneous
blossom up.
Yeah, and then they grow and it moves to the periphery. Here, like this is also an example. This is one homogeneous blob of contrast enhancement. But it's everywhere. It's supratentorial, but also in the brainstem, and also here, cerebellar, and in the temporal lobe. And then you look at the spinal cord. This is also a post-contrast scan. And I hope what you see here is that there is also severe contrast enhancement. So here in the cervical spinal cord, here. And I think, Vera, what do you think of this aspect? It also seems a bit...
Yeah, so here is quite striking. Remember our border between like the short lesions and the long LETMs, the long extensive transverse myelitis? We said the border is roughly 3 segments, so it's debatable if this is still considered short, but it can also be that those are several lesions that are confluent into each other. And then it all makes sense that those are MS lesions again. What is always good is to also have a look at the T2 or the steer, because it shows you the lesions differently. Here it could fit transverse myelitis. You have to check on the T2 only if you see this. But here we have, again, smaller lesions that are in the periphery of the spinal cord, so that fits MS.
Yeah.
I mean, she already has her MS diagnosis. We're not debating about it, but just from the imaging aspect, it sometimes can also look like something else, like one of the cousins.
Yeah. Sometimes the spinal cord can be so severely affected that you don't see the differences between the lesions anymore, and it looks like one long inflammatory lesion. Yeah. So, do we regret our decision of treatment? Yes, very much so. And I think in hindsight, we should have started with high-efficacy therapy in any case. We have Tisabi, we have ocrelizumab. I realize now that I haven't mentioned Tisabi at all anymore. That is because we don't prescribe it so much because of the risk of a brain infection. That is too high if you have the virus in the blood, and that is in approximately 60% of healthy people you have that virus. So that is a thing that makes that we don't prescribe it that often as we used to. Yeah.
Eva, I have a question. So once you start the second line options, has the patient become better? Like, does it work?
Yeah, very much so. Yeah, so it's as I showed you yesterday in the graph that 97% of patients over 2 years don't have any contrast enhancing lesions anymore. Right. Yeah, so that's quite impressive. And also in terms of new lesions, the far majority stabilizes on CD20 therapies. Yeah. So yes, so what I always say to my patients is that in 99% of cases, if you start this, people stabilize fully after 6 months. Yeah, and also in these severe cases.
One thing is, of course, the images, and the other thing is clinics. And like, for example, if I read hearing loss, this is something that very often doesn't recover fully, for example, or vestibular problems. And the image may stabilize, but the clinics sometimes remain with nasty side effects.
Yeah, that's true. So it's the scan stabilize, and we're happy that at least there are no new things happening. But that doesn't mean that a person also fully recovers. So the damage still exists, and it's a matter of time that you see if a relapse recovers or not. And mild relapses, they do recover often, but also often in severe cases they do not, and people have residual problems, and they can fluctuate. So over time, people could experience more of their symptoms, have periods where they walk less, or hear less, or have more difficulty swallowing. Yeah, no, that's a good extra thing that I haven't explained yesterday. So stabilizing is good, but it doesn't mean that a person is without any symptoms. On the contrary. So one of the last cases, which is actually quite very rare, nobody will ever see this again, but I found it quite interesting. So this is a patient who was 32 years old. She was admitted to the ICU because of severe cardiac problems. And this was a patient who was diagnosed with MS years before the high-efficacy therapy. And she started with interferon and then the dimethyl fumarate, and then she went over to another therapy, and all the times the MRI and the disease activity didn't fully stabilize. And then she started on Ocrevus in 2018. She did really well for quite some years, but then in 2022 she suddenly had a thing that looked like a cardiac arrest, and she had to be admitted to the ICU for care. And these are the two scans. She had one scan made a month prior to this episode. That is the scan that you see on the left, and then you have the scan that was made during this episode, and that is the scan that you see on the right. And the question is, do you see any differences between the two? Yeah, where do you see the differences?
On the left side, patients.
Yeah, this one?
Hyperintense area,
Yeah, here? Yeah, you're right. It's easy to overlook that area. What is the area, Vera?
This is the obex area of the fourth ventricle. So we're at the lowest part of the brainstem and just above the start of the spinal cord.
Yeah.
And,
and I realized I only showed you one slice. It's always difficult, but here are some other examples.
same patient, right? Same scan time? Or?
No, different patients. Different patients, yeah. This is actually a figure from a case study where they described multiple sclerosis broke my heart, where in very rare cases, and almost always in quite aggressive cases, you can have brainstem problems leading to autonomic failure, and in very rare cases also a necessity for ICU admission to help a person out of that episode. So she was treated with steroids, and this recovered fully, so there were no abnormalities on the EKG and the echo of the heart, and she decided to continue with ocrelizumab. But then we had the difficult decision or situation that in April 2024 she had another relapse. So she had an optic neuritis, and the brain MRI showed 4 new lesions. And there the question was, are there any options left?
Which therapy was she on?
Here, Ocrevus, CD20. Yeah. So this is one of the 1% cases where you see that people not always stabilize on Ocrevus. The answer is that you could switch here between the second-line compounds. So we sometimes decide to treat patients with Tisabri, the natalizumab anyway, even though they have this virus. And that, well, could cause the situation to stabilize. In the past, we also prescribed alemtuzumab, which you may or may not have heard of. That is also quite effective, but it induces a lot of other autoimmunity, so not a real fan anymore. And that is also the medication where I showed you the brain hemorrhages yesterday. So that is what we would call a third-line option. Yeah, and we have now since a year stem cell therapy for the treatment of MS, so I think this would be a candidate for stem cell therapy. And in Holland, we have insurance allowance to treat 20 patients with stem cell therapy, and that is reserved for people who did not stabilize on second-line options, both clinically as well as radiologically. So there you also need a clinical relapse to be eligible for stem cell transplantation.
Is that a bone marrow transplant? Because this is sometimes what I read, like bone marrow transplant in Moscow. Sometimes we see.
Yeah, that is what people do. Yeah, so
yeah.
In the last years, a lot of people went to either Mexico or Moscow. It's where they offer it. It's hematopoietic stem cell transplantation.
It's mostly autologous hematopoietic stem cell transplantation. We also run like 20 cases of stem cell transplantation. It's also like off-label use. We need permission from the Minister of Health, but it seems like it's effective, but we use it as a reserve treatment, and we also compared it with the alemtuzumab, and which seems like they are both comparable efficacy, but the side effects also quite similar. We lost some patients after hematopoietic stem cell transplantation, also after alemtuzumab as well. So the mortality rates looks like similar, but
and the fact that there even is mortality rates is compared to all the rest is that it's a third-line option. Yeah, you're right. Yeah, same here. And I think it's also good to know that the actual therapeutics, that the actual thing that causes the effect is the chemotherapy. So it's the stem cell transplantation is only to bring back enough immunity to recover from the chemotherapy.
And it's like in a cancer therapy, when I have leukemia, that I first get heavy radiation and ablative chemotherapy, and then I have no bone marrow cells left, and then I need a bone marrow transplant like a cancer patient.
Yeah, that's it. Okay. Yeah, and it's quite a lighter scheme because you have different levels of aggressiveness in these transplantations. The more aggressive, the better, but also the highest risk of side effects.
Like death.
Like that. Yeah, and So, but it is an option for patients like this.
Eva?
Yeah.
How about allogenic transplant? Has it been tried in these patients?
Yes, but also complications.
Right.
So that is always the downside. I mean, you hope for a therapy that has no side effects and is has the highest efficacy, and that also you in the future come to induction so that you actually cure MS. But with all these therapies, stem cell transplantation, other induction therapies, you see that there is at least a 30% risk or a 30% rate of the disease returning at any given moment. So it's not a perfect medication, even though people really believe in the effects of these types of treatments. One of the last patients, this is a female. She is 62 years old, also a woman, don't know why. And she went in for a checkup since she didn't have a neurological follow-up for years. And she had some new complaints. So this person had an optic neuritis in years before, when she was 36. And workup at that time showed no abnormalities on the brain scan. Normal CSF, so no oligoclonal bands, and the advice was then from, yeah, come back when you have new complaints. And that took quite some time. So in 2007, that is the moment of presentation, she was 49 years old, and she said, yeah, well, it's been a while, but I have some new visual problems, blurry vision, and perhaps it's also a bit painful, but the vision was still quite okay. So it was a little bit diminished, but not so bad. So the neurological examination showed signs that was consistent with optic neuritis. And remember that the first scan was completely normal. And then we did this scan. So now we're slightly moving into the more expert scans. What do you think of the localization and the morphology of the lesions that you see here? Is there anybody who dares to comment on this? She's 49. Oh, and she smokes. What do you think, Farah?
So the lesions have not a very nice round oval shape, really. They're more irregular, like you see like long lesions, you see zigzag lesions, they have all kinds of shapes. Yeah. So this is not MS typical. This is typical for vascular damage. However, if she's 49, then I have to still also say that this is a lot of lesions for 49. And also I see some lesions that are suspicious, like for example the one, can you go 2 slices up?
Yeah.
So this one might be a juxtacortical lesion, not quite sure yet because maybe there's still some white matter in between, and there was also on the left side something that looked like a perpendicularly standing periventricular lesion.
Oh, that was this one?
Yeah, that one. So this might be, if I just, as a guess, and I don't know this case, how it will evolve, it could be a mixture of vascular lesions and MS lesions. That being said, she also has a suspicious clinic. I would love to see the eye also.
Yeah.
Do we have eye evidence?
I think, do we have, no, we don't have that. No. Back in the old days. Yeah.
But currently I would say that it might be mixed pathology.
Yeah.
Vera, there were some intravascular things also. Not intravascular. There were some bright spots.
Yeah, but I think those are plexus artifacts.
Okay, so it's not
choroid plexus artifacts.
Hear this?
Yeah.
Yeah.
Vessel.
Yeah. And here you could also say that there is some slight asymmetry, that this looks also more than this, but it's a difficult case.
That could be vascular.
Yeah, I agree. So, and this is what happens, right? So we ask the radiologist, here's a scan, you don't get any clinical information, good luck with it. Make difficult decisions and please tell me if it's MS or not.
Is this the size of ventricles is normal? Is the size of ventricles
It's a
bit enlarged, or
it's a bit at the upper limit. I agree. Yeah. What you can also say is that her brain volume looks relatively normal, but there is variability between patients. So I must say she has quite some ventricles, but this is something that we see in quite a few patients.
Yeah. So there was no contrast scan, also no spinal cord MRI. I think we haven't mentioned it specifically, but spinal cord MRI can really help with the differential of vascular problems, because in aspecific white matter lesions due to vascular problems, you never see abnormalities on a spinal cord MRI. So if you would find a lesion in this kind of cases, then you're sure there is no doubt anymore. But some way or the other, we didn't do that. We thought, I think we thought that based on the combination of the clinical picture with the optic neuritis now on two sides and the fact that it happened also years in between, that, well, we said it's lesions present in more locations and also dissemination in time. But both the patient and the doctor decided not to start treatment because she only had 2 relapses with years in between, and now the vision still was quite good.
So how did you construct the dissemination in time, if I may ask? Because the first MRI didn't show anything?
Optic neuritis.
Ah, okay. Yeah.
And that was a clinical diagnosis.
Okay.
So now we need objective evidence, and this is a case where you could have a false positive diagnosis, but if it's a clear clinical typical picture, then So then in 2020, she came in because she now had slowly progressive walking problems, and that was over the period of 2 years. And she had increasing problems walking. The leg felt stiff. It didn't come along so easy. And hopefully you can remember the movie, the short movie I showed you yesterday, that was a spastic walking pattern, and that is what she also had. And here you see the 2 scans with years in between, 2020, 2007, and you can see clearly the evolving white matter lesions. So yes, there are a lot of aspecific white matter lesions. It's sometimes difficult to say that this is demyelination because it can also be vascular. But yeah, you have to trust me that there were indeed also lesions that were suggestive of demyelination. And now we did a spinal cord scan. And this was the definitive proof with this lesion. That is 1 segment, hyper intense on the spinal cord MRI. So, what is our diagnosis here? And should we call this PIRA? Does she have MS? Yeah. And what is the disease course at the moment with the slowly progressive walking problems? Secondary progressive, yeah, I think so too. So in this case, you had a relapse in '94, optic neuritis, no abnormalities on the scan, but I think it was demyelination. Then you had years in between, so you have to move this a little bit. You had a second relapse, and after that, shortly after that, she had slowly progressive walking problems. So clinically, you would call this PIRA. And if you have proof on subsequent EDSS scores that it's also increasing, then you have also objective clinical evidence for PIRA. But the thing that I went over quite quickly, and I'm not sure if you can see it on the screen here. It's very subtle. No, I think you can see it. There was this little bit of contrast enhancement in the lesion. So, it was, PIRA, clinical PIRA, but with active inflammation. So it wasn't the full neurodegenerative PIRA. And I think it's a thing that you would call, PIRA with MRI activity at the moment. And it's to show you that even in those progressive cases, the focal inflammation doesn't fully disappear. And that is because, that is important because in those cases, we sometimes decide to start treatment even if people are older and even if the predominant disease course is slowly progressive. I think that's it for now. Any questions?
I have a question about MS symptoms, just out of curiosity, because I'm not really a clinician. What I noticed in friends who have MS is that one of the main symptoms that we maybe have not talked so much about is fatigue, actually, which is something that is very difficult to grasp. They feel very tired very early. They need to sleep more than other people of their age. Does this have a radiological correlate, like on MRI, that you can say, for example, yeah, people who have like a higher lesion load are more likely to have fatigue. Where does this fatigue come from? Can you treat the fatigue?
Yeah. Oh, so many difficult questions.
Sorry.
No, I think it's the
But
most.
It seems to be very hassling for them. They cannot work full time because they're just too tired.
Yeah, it's a combination of so many factors. You have the physical fatigue if you have disability and walking problems, so that is an important thing. You can also have, there is no good word for it basically, but no, it's not mental fatigue because that seems that there is a psychiatric cause. It's quite biological, but also these types of fatigue. You have fatigue due to more cognitive problems, so the processing speed where you have increased attention. And we were discussing yesterday that that was more for depression, but I believe that could also be the case for fatigue, that due to the multifocal lesions, you can also have some altered neurotransmitter projections, maybe, that could also cause some subtle fatigue. So there are multiple reasons, and each have their own correlate. The interesting thing is that what I've seen now for quite some time is people come into the clinic saying, not sure what is wrong, but I don't feel that good. And then you say, okay, perhaps it's winter, the flu, etc. And then you make an MRI scan and you see 5 contrast-enhancing lesions. So I think it's a thing that we see more now that patients are less disabled and have less other symptoms that are less or more. How do you say that? More visible. More. Yeah. Yeah. So a long answer for no, we don't know.
Okay.
Yeah. Any other questions? No? All right, then I think it's time for coffee. Yeah. Now? Yeah? All right.